Testing.
Good evening, ladies and gentlemen. We are going to start the meeting. We've got a slightly changed order because different groups of people cannot participate in the order that they are in the agenda. So I would like to start with the Adult Services Report, which is, I believe, Lisa. So, oh yeah, sorry. I'm all over the show. Excuse me. Before we start the meeting, I will get the correct page open. All right. Do we have any apologies, Liam?
We have apologies from Phil Cunnington, but he may be appearing online.
Thank you, Liam. In terms of minutes from the previous meeting, does anybody have any questions, amendments? Do we need to take a vote on that?
Just a show of hands. Yeah.
A show of hands for approving the minutes. Unanimous. Thank you very much. Does anybody have a declaration of interest? What about South Central Ambulance Service? Are you involved with them still or not? Oh, sorry. It was the fire and rescue. Sorry, excuse me. I was just checking then. Yeah, the blue light, fine. There are no declarations of interest. Any public questions?
No public questions and no member questions.
Great. So, as I was saying, I'd like to welcome Lisa. Thank you very much for joining us, Lisa. And I would like to hand over to you.
Good evening, Adrian. Good to see you. Good to see everybody. Just wanted to start off giving apologies from Lorna Pierce. Lorna's poorly this evening. She's got COVID. She's Assistant Director of Quality and Safeguarding. And I'm surrounded by COVID at the moment. So apologies for not being in there in person this evening. I thought it was best that I kept a wide. But, so I think everybody's got the report, the quarterly report from Adult Social Care Agent. That's right, isn't it? So I thought I would just run through some of the highlights and then invite you all to ask any questions in relation to the report, if that's okay. So it's been a busy quarter as always. So just some of the highlights. We've been very excited to launch the Woking Borough Social Care Future Charter. I hope many of you in the room will be aware of this and have been involved when it came to full exec. And we were really chuffed that it was presented by our customers with experience, and they talked about where we want to go with adult social care, and it's all about the individuals that we're working with being central to their support decisions, making social care an everybody thing, not just those that are in the moment and needing care and support, and celebrating gloriously ordinary lives. So we've got some really good projects on the run at the moment in terms of the social care future. We've got one project which is looking at how people access social care, so how they come through the front door, and what was a good experience for people. So we've had a couple of really good workshops with a number of residents to tell us about what's working, what's not working in that space, and how we can make that better. We've got a second project which is looking at direct payments. And again, the aim of that really is to remove the barriers. It's a very process-driven service, and it's about driving up the amount of people that can have direct payments, which means they have more control over their life, and to remove all the bureaucracy around that. And then the third project is around our newly formed learning disability team that we now have in adult social care. And once again, it's trying to involve the carers and the customers with experience to develop a team that supports individuals in a way that suits them. So we're really excited about Social Care Future, and we're hoping that's really going to grow over the forthcoming months. A second highlight is the Berkshire Care Home, which is the home that we have purchased, now known as Bluebell House. So that's official now. And it's really coming on. We've got some refurbishment going on there, which is good, and it's starting to look very good. And we're really working on the quality improvements, having taken over from the previous provider. I think we've got 15 people resident there now, and we're hoping that when the refurbishments take place, that we'll get to grow the number of people living there and support with managing the demands in the local area, which we know is problematic. And another top win is our supported employment service, who are run by Optalis, and they are now ranked #1 in England for the number of learning disability individuals with a learning disability who have entered paid employment. They were second last year, so that's fantastic news for people with a learning disability in our area. I just wanted to reflect a little bit and highlight what the work that we've been doing around our social care pathway. Coming up to about 12 months now, we've been wanting to change our adult social care pathway. We want to make it simpler. We want the customer journey to be better. We want to have less handovers for people. So we've implemented a new pathway which came into place around November time. In doing that, we have reviewed everybody's job descriptions. We have made sure that we've got job descriptions which create a more agile workforce, so that we can go where the demand is rather than people being individual teams. And we've built some specialisms in there. So we've got a functioning dedicated reablement team. Like I mentioned, we've got a learning disability team, which we've got a team which looks at some of the longer term complex needs, such as hoarding and self-neglect. And the aim is that we'll have the right people working with the right people. So that's been an awful lot of work, and we're looking now at seeing some of the improvements. We're going to do a formal review of that in May time, and we acknowledge that there's been a period of instability for some of the staff members in terms of trying to implement that. It hasn't shaken our performance too heavily, which I've been very pleased about, but we're hoping that it will just drive our performance even further. So that's kind of our top opportunities and wins really over the last quarter. Challenges remain the same. Financially, we're under pressure. We know that. Demographically, we know that we've got an increased number of customers coming through our door, but we're just trying to do our best with what we have at the moment. We're trying to be innovative in the way that we're working with the people in Wokingham. So it's got there on the first page about our KPIs. We've got one KPI reported as red, which is below target this month, and that is regarding the social work assessments allocated within 28 days. As I mentioned, that's only just fallen below where we were last quarter, and I think I would have expected to see a change like that, given the fact that we've had a change in our customer pathway. But going forward, we are having some conversations about whether that performance measure is applicable to the way we're working now. What we are trying to do now is ensure that every single individual has an intervention between 2 to 5 working days. And then what we want to do is monitor the timeliness of our intervention to implement that. So we're trying to have a closer eye on what's happening rather than just when a case is allocated. So I think at that point I'll stop talking, and if there are any other of the performance targets that you want to delve deeper into, then I'm happy to take any questions.
Lisa, that was a lovely intro. That was helpful for us. I think it's always good to understand the big picture, and I think you did that in a very nice way. Thank you. I would ask for questions. I think Rebecca's first. Please go.
Thank you for that report. Obviously, I've picked up, it's hard not to, the KPI about social workers, and also it's one that seems to be fluctuating continually between red, amber, red. I appreciate that obviously you're looking at ways. It's quite interesting to hear, because is it necessary that everybody does need to be seen within 28 days if you're getting some kind of intervention? What kind of intervention are you looking at to put in instantly, say within a week, so that you're not missing something? Because my fear is 28 days waiting for an assessment. What could happen in that period of time? And if we're missing that target kind of routinely for the last year, really, haven't we? On and off.
I agree with you completely, Rebecca, and I think that's why we've changed the pathway, because I think that even though nationally we're actually performing way above other local authorities in terms of that measure, the majority have a waiting list of over 6 months. 28 days is a self-imposed measure that we put in place because we aspire to be better than that. But I think you're right. It didn't feel right for us having that as a measure, because 28 days is too long for somebody to be seen, which is why we've changed our pathway. And now the goal we are hoping to get passed off in ASCLT is that every single individual that comes through that front door will receive an intervention between 2 to 5 days. Now, that may mean a visit. So it may mean somebody actively going out to the individual's home, seeing what the situation is. But more importantly, it will mean risk assessing and triaging that individual in that moment, and making sure that a service is put in immediately. So that person will be safe. And that's the key thing for us. And then from that, we will go on to have the service, and which is why I then want a timeliness measure attached to that, so we don't have a long gap between that initial intervention and then the interventions that people have on a longer term don't spiral. I want to keep a close eye that we're actually having outcome measured interventions with individuals. So we just want to take a slightly different perspective on it, and I think we're going to have to monitor that. And we're going to have to see whether that works better. But we've already started this, Rebecca. So we've already put this in place since November. So we're reviewing in May with the hope that we will be able to change this performance target, and we'll be able to show that we're doing things in a different way, in a better way.
So if I can just come back, the triage thing sounds good, because obviously that, initial assessment is the most important thing, and then allocating the resources where the priorities are needed. Are some of the reasons as well for the timeliness still the lack of recruitment when it comes to social workers? Is it still because we're low on social workers in the borough with empty posts, or are there other reasons? Sorry, I won't keep you too long on the same question, sorry.
Yeah, that's absolutely fine. It's good to talk about it. We've got about a 15% vacancy rate at the moment. However, saying that, I make business cases for locum workers where it's needed, because we are in an area which we can't afford to carry vacancies. So I'm not sure it is actually staffing that creates any delays. It's the demand, really, because we have a high demand of individuals. We also have a high number of private funders locally who still have a right to service, who still have a right to come in and have that advice and support. So part of the work that we're doing through Social Care Future, when I mentioned about looking at our front door, is about really pulling together how we're working with our voluntary care sector and how we're working with our health services, so that we have a more integrated response, because not everybody needs to see a social worker. It might be for some individuals actually who are lonely, that the VCS can provide that level of support very, very skillfully. So we're trying to work to have really, really close relationships, so that when that person comes through the door, we're having the right conversations in that moment with the right people, so that we can get the right wraparound service around the individual.
Tony?
Hi, I just had a question about the CQC registered providers that are rated good or outstanding. That wasn't. It's an amber one on your list. I just wondered whether, and it says following that the domiciliary care was better, but the nursing was worse. I wondered what the situation was in terms of. I'll be short. Is it problematic getting hold of the nurses in these situations, or is it? Do we have various providers that we can choose between, or that sort of thing?
It's definitely an issue for us, no doubt about it. I think the stats are very variable, because actually we have proportionately quite a lower number of nursing homes in the area. So you know, if somebody goes into a bad position, it will show very differently on the stats. Saying that, we struggle locally, which is one of the reasons that we're going ahead and we've purchased Bluebell House, and we want to drive the market. We want to drive the quality of what we're able to offer a bit more. And I know there's several more conversations happening about that. And I think finding quality nursing care can be problematic. We've got a very, very good quality assurance team working in Wokingham. If Lorna was here, she'd be talking about this now. And they offer a lot of support to our providers and our nursing homes, etc., to try and drive that quality. And they do some really proactive work with them. But we acknowledge that, you know, the variety, the availability of nursing care is difficult.
Thank you.
Beth?
Thank you. Can I follow up on the KPIs, please? Because the ones halfway down the page that have been amber for some time, one was amber, green, and then back to amber, and AS6 has been amber for the last 3 reports. Are the issues that prevent it from being green in our control or not in our control? And is that, again, a staffing issue?
Okay, so they vary, actually. So, for example, the AS5, that's about the number of people that have had their care services reviewed in the last 12 months. Now, if you look at the statistics, they run, our target is 70, which again is a self-imposed target. We're higher than other local authorities in that area. And I think it runs between 69 and 70. So we're there, we're teetering on it, but it's a self-imposed target. And I want to drive improvement on that even higher, but I think we are benchmarking okay there. I think in terms of AS6, that's one which is more out of our control. That's in terms of the market and what is available. So it's whilst we have measures to try and support those homes, a lot of that can be outside of our control.
Rebecca?
I just wanted to follow up on the one about the domiciliary care that you've written in the report about a provider that's recently come into the borough. And unfortunately for you, you've now inherited that, and the issues that they have historically been performing very poorly, which is worrying if their officers come into the area and they're providing poor care for, you know, some of the most vulnerable in their own homes. And I know what we want is for people to be in their own homes, but the concern is, you know, that they're providing poor care. So what can you do with this particular provider, and I mean monitoring it going forward if they're providing care to our residents?
Yeah, it is a concern. We have a very robust care governance system in Wokingham. Lorna chairs our care governance board. That is a partner system. So we have adult social care in there, we have health, we have a range of representatives, so that we can understand what's happening in the local area. Any concerns that are reported via social workers, via external partners, etc., are fed into that. And if we believe we bring that intelligence together, and should we have any major concerns, then we have a grading system in terms of how we might monitor that. And that would involve our quality assurance team, who would go out, they would be scrutinising, they'd be monitoring that. If the level of concern raised, their alert would be raised to the point that we might be embargoing people that we are working with. And we have a very, very close relationship with CQC in terms of monitoring that as well. So the system in place is robust, I would say.
And this particular provider, I mean, are you monitoring them very closely? Are you due to look at them again, reassess them now they've come into the borough? Is there a short period of time that we give them to see how they're working? I mean, or, you know, I'm hoping they're not left for a year or so before, you know, how are you monitoring this particular provider?
Yeah, all of the providers are monitored anyway through our contractual process. Anybody that we have concern about, I'm not sure in terms of this exact, I'll check this for you if you like, with Rebecca, in terms of the exact provider. But if they came in at level of concern, they would be on our either our radar or on our cautions list, and we would continue with that level of concern. It wouldn't just be left. And we have them monthly, the care governance meetings. And we have one which is at an operational level and one which is at a steering group level.
Phil, are you online? Would you like to ask a question?
Yes, please. Hi, Lisa.
Hi, Phil.
Hi. It was actually a quick one. It was to do with the what I presume is related to some of the work on health inequalities that is going to be happening. But I noticed that the increase in life expectancy for females have taken sort of quite a dive between, I assume, 2018 and 20. Is there particular demographic changes in the area, or is there anything that we can put our fingers on, or do we think we're going to learn that sort of stuff as we step into the Marmot environment?
I would imagine the Marmot is going to tell us a lot, but I'm going to pull on my colleague Ingrid as if by magic, who will know a lot more about this than me.
Evening all. Yeah, it's a really good question, Phil. I think we don't know yet what is driving our health inequalities. So in terms, that will definitely be part of the Marmot work, trying to understand that in more depth. And we can absolutely see the variation of that statistic in terms of life expectancy across our neighbourhoods. So that is something we can see, and we know where people have a longer life expectancy and where people have a shorter life expectancy. That metric is it's an annual metric, so it's a difficult one to be. It's not a sensitive marker of how health is in general. So we have to interpret it with a level of caution. And actually, the real potentially the marker that we need to focus on quite a lot is healthy life expectancy. So we know that that it's not just about longevity, but how long people live in good health, and we know that that is also changing. So we need to understand it in greater depth outside of that aggregate, and that will be part of our work over the next 9 months with UCL and the Institute of Health Equity.
I knew she could answer it.
Does that answer your question, Phil? Are you okay?
Yeah, that's great. I mean, I recognise that I'm talking about a negative move on a positive line, which is always a difficult thing to discuss. But I mean, I also recognise that in areas like dementia and various others, we are actually keeping people healthy and well for longer. So it's a little bit of a surprise to see it drip, but at the same time, I heard what Ingrid said, and yeah, let's get our fingers underneath those numbers and start to sift out exactly what they might mean for us.
Thanks for that, Phil. If it's okay, I'd like to ask a few questions. At the start of this, Lisa, you described you're making, it sounded like sensible choices in terms of trying to streamline the pathways. And as part of that, you described that the teams are becoming a little bit more flexible, so they can move around and follow I would say, the peak area of focus in a process pipeline. My question really is about the staff. Are the staff agreeing with this? Are the staff happy with this? Is this being planned in a way that the staff are on board with it? How's morale?
Yeah, morale's good. So it's been a fascinating 12 months actually, because we've talked about wanting to do pathway changes for years actually, and we went ahead and took the bull by the horns and decided that we were going to do that. Staff were initially concerned, especially when you talk about reviewing anybody's JD along the way, but actually they have absolutely embraced it. And what it's about really is for the majority, their day job will, largely remain unchanged, and they'll be working with the group of individuals that they enjoy working with. But we have to have a workforce which is agile and can meet demand. So if all of a sudden, our front door becomes so pressured that we can't do the 2 to 5 days, we have to be able to respond to that. We're not going to magically get more money from somewhere else. So we have to have a workforce which can meet the demands and the pressures. We've had initial feedback from the changes that we've made. I think that was about 2 months after Adrian, and the initial feedback was really, really positive. And I think staff are feeling that they are able to concentrate on things in a different way now. I think they were jack of all trades previously, because we had a generic workforce that dealt with all different customer groups. And I feel that they, in the main, they have the client groups that they enjoy working with, but we have that degree of flexibility so we can adapt and change. Fingers crossed. It seems to be working.
Thanks a lot for that answer. In your commentary as well, you talked about the conversion of Berkshire Care Home to, was it Bluebell House, I think?
Bluebell House, yeah.
Yeah. And you said that there was some refurbishments, updates being processed to the buildings and infrastructure. Is that a big budget? Do we need to worry about that, or is that a relatively small budget?
I'm probably not best placed to answer that question, Adrian. So, but if you'd like me to get some feedback regarding that, then I'm really happy to do so.
Yeah, I think that would be useful to understand, because builders always take a deep intake of breath when they start digging a hole, and sometimes the price of things goes up dramatically. So I'd like to keep an eye on that. And also, you talked about the number of patients being referred through the process to that care home specifically, which is a good thing. I mean, that's the purpose of having it. But obviously, if the project to do the updates and remediations goes on for a long time, then eventually that will constrain the capacity. So I wanted to get an idea of how long those updates are going to carry on for. I mean, when do you think you'll finish the first proper phase of updates?
I will get that information for you, Adrian.
Super, thanks.
Happy to do that, yeah.
I'm going back to the report on the front sheet and challenges. I know you keep, WBC keeps a very close eye on all the providers, I believe on a monthly basis. But in the report, it says, with a number of social care providers experiencing difficulties. Are we at the stage where we need to think about stepping in, or is that 6 months away or 12 months away, or what's your feeling?
I would say we're not at the stage where we have got a major crisis or a major problem. I think that up until very, very recently, we've had an excellent market actually, and we've had a lot of availability in the market. The last maybe month or two, we have had some problems in terms of some of the provider ratings, as you can see, has an impact on what might be available for us. But our care quality team are working closely, as are our contracts and strategic commissioning team. They're working really closely with our providers. They have provider forums. Attracting staff is difficult, we know that. So again, we're trying to work with our providers around that. I'm happy to defer to Wes to maybe have a more in-depth conversation about this, but I think he would reiterate that we're not there yet.
Next question is about AS4. So AS4 certainly seems to be going in the right direction. Is that the impact of Bluebell House, or is it something else?
Not yet. So I think it's the impact on. I think staff are working really hard to keep people out of nursing and residential care. We're doing an awful lot of work, as I've mentioned, at the front door now, trying to make sure that we're putting as much support into people's houses as possible. Also trying to get in there before a crisis is reached. So I think that Bluebell House hasn't made its footprint on that yet, but we're certainly hope it will going forward. The whole point is that we will have availability there, number one, and number two, it will drive the market around costs, because we're experiencing more and more increasing costs, and that will be able to regulate the market as well.
Thank you very much for that answer. Final point, which is a request. It's not a question. We have our friends from Bob presenting later on, and they have this idea of really an integrated care system. And part of that integration means IT integration. And if I was to paint a scenario, which, is probably what is, I don't know the current IT integration, but I would expect that if a hospital is going to put an elderly patient, getting that elderly patient ready to leave hospital care and to move into some kind of care plan with the local authority, I presume a lot of that process is driven by phone calls or emails or whatever. Now, some of the answers I've got from Bob imply that there will be really deep IT integration, and this means that the concept of, for instance, the care team in the hospital creating a record, if you like, which is to be sent to a local authority through an electronic interchange to an IT system in WBC to say, you know, in 2 weeks' time, we expect this elderly patient to be coming out, and they need their medical situation is X, Y, and Z, and they probably need ABC maybe as a care plan. One of the things I would like to see in these KPIs, and it would be a new KPI, and this is my request, is IT integration with Bob, because if there is no IT integration, then we indefinitely rely upon phone calls and emails, and I would call it informal communication rather than an IT system where there is an incoming patient record or an outgoing patient record or a transferred patient record or something like that. So, you know, this would also apply to patients where the care plan is failing and the patient needs to go into hospital. You know, so eventually, you know, in this type of process, you end up with a huge admin overload of telephones and emails and whatever's, which can be speeded up by an IT system. So I would like to see how well WBC is doing with IT integration to Bob as a KPI. And I don't expect any sort of immediate answer, but
I think,
you know,
sorry, Adrian. I think what I would say is this is a conversation we've had with the SCB for a very, very long time. The barriers and the hurdles to integration of systems, is incredible, actually. We have a system in place which is called Connected Care. It is far from ideal. All it gives us are some read-only information about some customers. We have so many separate IT systems at the moment, Adrian, across adult social care and health, you know, from our colleagues in CMHT, who will have a different system to a GP surgery. So I think we're a long way from that, in my humble opinion. I would like nothing more than to see that as well.
That was the answer I expected, to be honest. But if there is an ambition to streamline processes and reduce admin, then IT is the only solution in my experience. And you know, when I've been asking these questions of Bob people, they give I have to be careful with my words here. They give off the cuff answers where they say things like, well, I'm a GP and I can see this person's record. I can see what they're getting in the pharmacy. I can see their x-rays from hospital. I can see everything about this patient. Now, that was the answer that was provided to me 2 weeks ago. I thought that is a very rose-tinted view of the IT integration of this world. And I know it's a lot more complicated than that answer. However, you know, we can employ, you know, effectively an infinite number of people on telephones and email executing a process, or we can spend some money on IT to support the experts to make sure the right person goes to the right place. And I would like to see how we and the provider, which would be Bob in this case, for, you know, I think the anticipation is that Bob will be working on integration, how they are delivering integration to you. And if they're not delivering integration to you, then I can stand in front of Bob and say, I've got my KPI pack from the local authority and you haven't done your IT integrations. So the local authority cannot see your data. if I don't have a KPI, I can say, well, we have people on the telephone and people on email because of, it's not as good a driver of performance and behaviour until I've got something in a report. And I see this as a KPI, and I see this as red for possibly years. Yeah. However, there should be, we've spoke to Bob, and this is the situation. Bob are going to provide this in a year's time. Bob are going to provide this in 6 months. Whatever it is, we need to get that tracked and recorded so that I can stand in meetings and pin them down and not get anecdotal, off-the-cuff responses to specific questions, which, as you can perceive from my voice, I was very dissatisfied with their answers, because I spent 35 years in IT and I know it's complicated. So this is to help us. It's not to point at WBC and say WBC are not doing anything with integration. There is an
understood. Understood. We'll I'll take that away and we'll give it some thought.
Please do. And even if it is in the commentary of the overall thing, I need to know where we're getting to with integration. But it's been thank you very much for your time. Any further questions? Shahid, please.
First of all, Chair, I think my apologies for coming late. One comment and two questions, if I may. One is to actually echo the point which Adrian made, because we've got a similar background, Adrian, so I fully support that. And I've actually raised this issue for a number of years when I was responsible for corporate insight as well. And the answers were not satisfactory. Perhaps, when we have so much cost pressures, there are a lot of things which can be automated. And that's where the solution lies in terms of actually being much more efficient, much more smarter way of doing things, and rather than just doing the way things have been done before, right? Our whole approach seems to be, not only in this area, but my observation in other areas as well, is very reactive rather than actually being proactive. What this information gives us with the systems you're talking about is actually, it gives you advance warnings. Look, things are coming in 2 months, 3 months, 3 weeks. We can plan according to that rather than being reactive when things happen, and then we have to emergency react to that. I think, yes, there will always be some sort of reactions, but I would say at least majority of the cases, there could be some forward planning, but IT integration, data insight will actually help in that process. I see this is not as a cost. Personally, and my observation and my experience has been, it is investing to save. We invest in the short term, but actually in the long term, it makes us much more efficient, effective, much more targeted service which we provide, and also in the long term actually saves us money as well. So there's a long comment, right? There's a
understood.
In terms of, just coming back to the questions, one regarding the providers, registered providers. I think we know that there's a lot of cost, they are under a lot of pressure as well. Some of them actually had to close down because financially it's not efficient. Lisa, can you take us through, for example, if a particular provider goes bust and they are taking care of, obviously you've got a contract with whatever number of clients from WBC, and they say, look, they come to you and say, look, WBC, we cannot provide this service because financially it is not viable. End of the day, they need to make their bread and butter as well. That's why they're in the business. What is a process you have to go through? Perhaps if you can take us, that would be really useful for me and perhaps for everyone else as well, to know what process would you go through. That's number one. Secondly, you did mention staff attraction. Yes, I think we know that not only for the council, but also for the service providers as well. And we know also that one of the reasons is because the pay care workers get is very low. Inflation has been very high, and their actually salary has not changed over a number of years. The rates are exactly the same when we had inflation at 10%, and all the way. So they actually effectively are getting poorer and poorer as a result of that and providing the same service. But they are not actually getting the same amount. So how does actually the council, does it take into consideration the cost of living? Does it actually accommodate their funding based on how the inflation is rising, or is that actually contracted for the next 5 years? That's how it is, and you have to deal with it basically as a provider.
Thanks, Shahid. I'm probably not the best person to respond to this. I can talk very basically about this, in that, our contracts and strategic commissioning team do work really, really closely with providers. The last thing we would want is for a provider to go bust. We know how much valued they are locally. And there would always be conversations about how we can support them financially or otherwise to try and keep them going. But I would prefer, if it's okay, Shahid, for maybe me to get something in writing from our Assistant Director of Contracts and Commissioning, just so that we've got that totally accurate. That might be fair. And again, with the cost of living, you're right, it's constantly, driving costs, isn't it? The uplift process is done on an annual basis. So every year providers will have conversations with our contracts and commissioning team about increases, overheads, cost of living, all of that. A percentage is offered by the council, but then any of the providers are invited to come back if they feel that it doesn't meet their need, and a conversation will happen about what is a fair figure to put on that, given their individual circumstances. But once again, I'm really happy to get a more detailed response from Wes, if that's helpful.
Thank you. Any further questions for Lisa? Thank you so much, Lisa. Really appreciate your time. Thanks a lot for you. I thought your presentation at the start was really perfect, because it was a lovely description of what's going on, and it gives us a real insight rather than just KPIs, because just KPIs are on their own a bit like Weetabix without any milk. They're very difficult to digest.
It's lovely to join you. I'm really happy to come back at any point.
Thank you very much. Really appreciate it.
Nice to see you all.
Ciao. I think, who have we got next?
The ICB update with Helen now.
Oh, brilliant. Is Helen there? Oh, hi, Helen. Thanks for joining. I'll leave you to do the ICB update.
Helen, you're on mute.
Yeah, you're on mute.
Could you just hold on 1 second? Sorry, I'm just trying to sort my microphone out.
We can hear you now.
Okay, sorry, can you still hear me?
Yes, we can hear you, thanks.
Yeah, okay, that's lovely, thank you. So yes, this is a standard update report. I think we've touched on this in previous meetings. So we prepare these reports primarily for the Health and Wellbeing Board, but very happy to also bring them here if helpful. So it's a fairly short report that we've brought this time. Key areas covered, we've highlighted our ICB board meeting, and the link to the papers. We've provided an update on the primary care strategy, which I know we discussed in quite some detail at the previous meeting. In terms of where we're at on that, the engagement exercise that we were conducting closed on the 29th of February. So we've been busy digesting the feedback and input that we've had through all elements of that engagement process, which was conducted in conjunction with Healthwatch, as we described last time. We are developing a report on public involvement, which will be published sometime during April, and we will also be developing a final version of the strategy to go to the IC board for agreement in May 2020. Obviously this year. What we were hoping is that alongside that we'll have an implementation plan, and again I think we talked about this last time about the key themes that this will cover, and that we see it as an iterative process in which we would want to continually involve patients and members of the public in taking this work forward and in understanding the experience of primary care and views on how we develop services further. But yes, in the first instance, really work to finalise the document underway, and we actually have a stakeholder workshop tomorrow as the next step in that journey of developing the strategy. We've also provided a further update on the impact of industrial action as outlined in the paper, and also an update on the vaccination programmes which are currently ongoing, a particular focus on measles currently. And we've set out some of the activities that are underway to ensure that anyone who has missed out on a vaccination is being encouraged to come forward to catch up with vaccinations that they may not have had, and also highlighted the next phase of the COVID vaccination campaign, which is a spring booster campaign expected to start in mid-April and covering particular groups as set out in the paper. So I think that's a quick summary. I'm happy to take any questions. Thank you.
Rebecca, please.
I'm just interested about the vaccination programme, getting everybody with the uptake. There's quite a lot of press at the moment about outbreaks of measles. So what are the barriers still that we're finding locally? Is there particular cohorts of children, families that are not uptaking the vaccine? What are we doing about it? Or, you know, because obviously years back we had all the misinformation about autism. You know, what are the real concerns about parents and why they're not getting their children vaccinated still?
So I can see Ingrid has got her hand up to answer that, which I think would be helpful as she's close to the work on this.
Realise I've gone into the dark. Sorry about that. Oh, that's better. Yeah, so really interesting question, and one we just need to. So there is definitely areas of measles outbreak in the UK at the moment, largely in the Midlands and in London. There are no measles cases in Berkshire, and there are and haven't been. So we just need to be clear that we're not concerned about any sort of imminent growth of measles cases, but clearly we're learning the lessons from colleagues around the country and making sure that we have maximised our uptake. Second thing to note around MMR is we have really good MMR uptake in Wokingham. So first and second dose uptakes are over the national target and are over 90%. So we have really good uptake. So that's the second thing to note. Thirdly, exactly as you've asked, what's happening with the remainder? I think it's about 5% for the first vaccine and about 10% for the second vaccine that haven't had that second vaccine. We have been able to, so Public Health took upon ourselves an exercise to look at the data when the measles outbreak were happening in the Midlands, and looked through the GP data rather than anything else to see which practices had lower uptake. And there is a geographical concentration around certain practices, and we are going to work with those practices particularly to try and deliver the message to families. There's a certain element we think that will be about COVID access to vaccinations through the pandemic, but beyond that there will be some, I'm sure, cultural resistance to vaccination. But I don't think that in Wokingham we see a blanket or in any particular community an aversion to MMR from historical stories. I think that is we've passed that in terms of our uptake figures in Wokingham. So I think for measles, it's a good story in Wokingham, and it is really trying to focus on the very small number where we haven't had vaccine uptake.
That's actually really reassuring to hear, and glad that it's moved on finally, and people are doing the right thing. I mean, that's a personal point of view, but yeah, I'm glad to hear that.
Good. And I must probably need to say just one thing, is that one part of the measles campaign, and I'll say it now, particularly if this public meeting, if anyone's listening, that there is a generation that missed out on their MMR to a larger degree than the current generation. They are still eligible to get their MMR now. If you're an adult and you haven't had your MMR, you can still get it now at your GP. So it's important, if you're talking to residents or if it comes up, the MMR is not just for children. That's when it's in the childhood immunisation schedule. But if you didn't get it, ask your mum, get everyone to ask their parents. If you didn't get your MMR, it's not too late to get it as an adult.
Question, I'm not sure who for. I just wanted to check, we're going through another spring booster for COVID. What sort of incidence of COVID have we got at the moment?
Ingrid, also take that one. No, that's good.
So COVID levels are low, but the way in which that's measured is not reliable, is what I would say. So they went up over winter and they're now back down, on the way down, but we don't test people for COVID. So the only way that we know what the levels are is by checking certain people with certain symptoms in the hospital, and they do sort of random sampling of populations not in Wokingham, so, and then extrapolate. So the measuring is poor, and they would, the general sense and direction is that we don't need to measure it anymore. It is becoming a routine illness, and that we don't need to be aware of the actual number of underlying cases.
Thanks for that answer. I mean, firstly, thanks, Helen, for coming and presenting the report. I don't think there's anything particularly contentious in this report. It's just an update. I did go and meet Sanjay, and we had a very, very good meeting and a very positive meeting. And you know, whether I'm sitting here giving you a hard time or giving a GP a hard time or whatever, it is all for the same purpose, and that is, you know, I regard as everybody as in this together, and we need to support each other through this Bob integration into this integrated care system. And so I was very encouraged by the meeting with Sanjay, which was great. Maybe on the back of the previous meeting, you heard me waffling on about IT. I'm going to continue to ask questions of Bob about IT, because one of the constraints in terms of resourcing is handovers. And, you know, where you don't have compatible IT systems, you have informal processes like telephone calls, like emails, like non-tracked communication, which means that when a hospital admission is in or out of a local authority care system, that's not controlled, that's not recorded in an IT system that's integrated. And that leads to an awful lot of effort on the clinician's side at the hospital, and on the clinicians and experts and social workers on this end. So we all end up spending, you know, loads and loads of time on one person who's transitioning into hospital or out of hospital into local authority care. And my firm belief as an IT guy is that if there was an IT system to support that, with, you know, a transfer record going either way, this would reduce the amount of time we spend on the telephone and in emails, which will ultimately make us all more efficient and make us all more capable of coping with the increasing need we see from an increasingly aging population. But there are no specific questions for you on this point. But just to let you know that I will be trying to track this from the WBC end, and I've asked them. I don't know whether they will accept this, but I've asked them to create a KPI for this so that we can track it. And if we do start tracking it, then I will start asking questions of the status, both of WBC and both of Bob, just to let you know.
Yeah, noted. I mean, obviously, integration of IT systems is absolutely a priority for Bob and for the wider system. So I'm sure that's a subject we'd be happy to discuss at some stage if there were specific questions raised.
Thanks a lot for Helen.
Thank you.
Any further questions for Helen? Super. Thanks for your time, Helen.
Thank you.
And again, say hi to Sanjay and thank you.
Yeah, no, I'm glad you were able to meet with him. Thank you. I'll dial off now if that's okay. But
yeah, that's fine, Helen. Thanks. And we've got Kirsten joining us. Thanks a lot, Kirsten, for joining us. I think these kind of meetings normally proceed on the basis that we've read your slides. If there's any particular points you want to highlight or any particular graphs you want to highlight, then feel free to present. But we don't want a monologue presentation of the whole pack, if that makes sense. And we like to go to questions fairly early, if that's okay with you.
Of course it is. Thank you and good evening, everybody. I very much appreciate the opportunity to present to you this evening. Just checking you can hear me okay.
Yeah, we can hear you fine.
I think first off, just to say thank you for accommodating my timings this evening as well. As you know, I've been called to present at the High Sheriff's Awards this evening, so wasn't able to join you in person. So apologies for that, but thank you for accommodating me on Teams. I think probably the one point that I would probably draw your attention to is the challenges that we've been experiencing in the ambulance service in recent times. And most particularly the critical incident we were asked to draw particular attention to. As you might imagine, the pressures that we've all been experiencing within frontline healthcare services, whether that be in the ambulance service or whether that be in the acute trust, has obviously been quite significant and has been quite sustained. In fact, we've seen quite a level of increase of activity and pressure ever since we came out of COVID. We've not returned back to the pre-COVID times at all, and in fact the way in which people are using services has changed quite considerably. That resulted in our declaration of the critical incident, which we declared on the 23rd of January this year. What we were experiencing in the days leading up to it, we were anticipating that we were potentially going to end up in this situation. But of note, on average, we would normally see approximately 60% of our workload, sometimes as low as the high 40s percentages wise, of category 1 and category 2, so immediately life-threatening and serious category 2 cases as our daily sort of average. And we were starting to see it slowly creep up day by day. And by the time that we declared the critical incident, we were on 72% of our workload. Now, that's obviously very concerning to us because as we would describe the acuity, so how ill the patients are, was really impacting on our ability to deliver a safe service. And in turn, approximately 70 to 80% of those patients are conveyed to hospital, and the vast majority of those result in an admission as well. So as a result of that, obviously the hospitals end up being under a lot of pressure. The ambulance handover delays, obviously, as you saw, were significantly increased, with 529 hours that were lost across our geography on the 22nd of January. In prior days, it had been only 150 to 200 hours. The Royal Berks themselves, obviously our specific local acute hospital, saw in the 22nd of January 89.5 hours lost. actually that did actually decrease when we declared, which is not an unusual thing for us to see, and that's as a result of essentially it's as though people respond in often a way as though it's declaring a major incident. This is obviously a critical incident, but they behave in the same or similar way, and they start to get the systems flowing through. We had already been supporting our enhanced patient safety plan, which is essentially a way in which we don't dispatch ambulances to our category 3 and category 4 calls, so the less unwell patients. So that was the significant factor that we experienced with regards to the experiences of that critical incident. I will say we were extremely well supported by our partners within health, both at the Acute Trust and with community partners as well, which afforded us to only have the critical incident in place for a few days, which was good, and we were able to recover relatively quickly. And we haven't returned to those sorts of levels. We've had odd days when we've hit 70%, but we have been able to absorb it a lot better. But I suppose it's just around making your good selves aware of those challenges, as I know you are fully aware of them, but also how, like I say, how the way in which people are, they're certainly more ill, without a doubt. We are certainly seeing, like I say, the higher acuity cases coming through, which is naturally impacting onto our ability to deliver safe services with the demands increasing as they are. So happy to take any questions. As you say, you don't want me to go through the entire slide set, which is understandable. It's getting late, I'm sure, but happy to take any questions as you see fit.
Thank you, Kirsten. That introduction was perfect. Thank you. Rebecca first, please.
Thank you. Interesting to see about that you were saying about this rise in the category 1 and category 2 calls. Are there any factors that are behind it? Is it a seasonal thing, or with illnesses, or is it down to people maybe not receiving care at home, GP support, and then it's kind of systems getting worse and worse, and then they're ending up calling an ambulance because it's got too bad? Are there any big factors that anything can be done about to stop this from happening?
I think thank you for your question. It's a great question. I think there are a number of factors that come into play. We have an aging population, particularly in our local area and within the wider Thames Valley as well. So we do have an aging population. We are living longer. We have greater healthcare needs. Respiratory illness, it tends to be one of the largest aspects that we are called to. We've certainly seen a change in the way in which patients are presenting with respiratory illness post-COVID, which I suppose is to be is an understandable place for people to be. I think accessing other services, I think, is from my personal experience within the ambulance service, we don't have an issue particularly accessing support from primary care partners. I think people often think that they can't. So whether we have a messaging issue that perhaps goes on, because we certainly do have those conversations with patients and relatives. When we arrive on scene, I can't contact a doctor, will often be muted. But actually, it's more myth than reality. We might make a phone call and be able to get them seen. And of course, we have the 111 service within our ambulance trust as well. And we have really good access through to primary care through those routes, and to other, pharmacies and other community-based providers as well. So I think it's more, respiratory illness has certainly gone up. We are living longer, so healthcare needs are greater. And I often think that from what I observe is patients leave things too long, almost that you try to do self-care, and before you know it, you kind of topple off that precipice, and actually you do become really unwell and have to then be, have a need for the ambulance service or acute trust presentations at the ED in particular.
I think you do have a point there, because there are people that you know, maybe fearful because they hear about all the negative press about seeing the GP. I mean, there's a lot in, you know, there is a lot of education around about, you know, accessing your pharmacy and your GP, but there are still people thinking, I don't want to bother anybody. And especially with an aging population. And then, as you say, by the time they get to you, it's almost a bit too late. And, or well, it's not too late, or the treatment then required is a lot worse.
Yes.
You know, which something that could have been nipped in the bud. So, I mean, I suppose it's all about education and making sure the message gets out there for people seeking help if they're unwell early on.
Yeah, and I mean, we have extremely good community services. You know, I'm thinking of GP out of hours services in our area in particular, are very, very good. But you're right, Monday morning, the length of time that people are waiting to get through to their GP on a Monday is much higher than if you try and make a call on a Friday. And we see that impact on the numbers of arrivals at the ED, and the number of attendants at the ED on a Monday and a Tuesday is always far higher, because often they won't have wanted to contact, or they don't understand that they can contact GP still in the out of hours and over the weekend processes as well.
Shahid?
Thank you, Kirsten. First of all, can I, I'm sure on behalf of everyone, commend the work which our ambulance services do. You know, it's from personal experience, 2 cases in our family. Without the right timely intervention, perhaps they would not be with us. So it was literally, you know, when it's an emergency, is you're talking about seconds and minutes here.
Sure.
So I just want to thank you, you know, for all the services which you provide. Other thing is, because I just want to understand, obviously there's lately a lot of the time when ambulance takes a patient, it has to wait a long time at the gate before they are admitted. Probably the reason being, I assume, that there is no bed available. And a lot of the cases, the reports I've read as well nationally as and locally, that because a lot of the patients are ready to go home, but because there's no one, elderly people, there's no one to actually provide them the care at home, right? So because they had operation, for example, they need at least 3 or 4 weeks of rehab. There is no one, you know, they live single, and there's nobody to provide that. So beds are occupied. It seems like obviously everything is linked, and that's what you hear in the reports. But what you think is perhaps would be useful for me, and I'm sure for everyone as well. What are actually the blockers here? Why the patients have to sit in ambulances for so long before actually they're taken in? And obviously, and you hear that even A&E, the patients go in, they have to wait 4 or 5 hours, sometimes 6 hours, just to be seen by the doctor. So it's, you know, if you add the time, by the time that they're taken by the ambulance, waiting in the ambulance, then they're taken to the hospital, and then it just takes like a whole day or a half, at least 12 hours before they're even seen. So just it'd be helpful to understand what are the blockers from your point of view, or how you see it.
Gosh, thank you for your question. It's a big question. I'll try and capture it as best as I can. So I think what you're describing is what we would describe as end-to-end care. So obviously when we arrive, you know, we play our part in the community, whether that's come through the 9s or the 1s or through a healthcare professional contact, and we convey through to the acute trust or the most appropriate hospital. What's interesting about the model at Royal Berks, if we bring it locally, is and it has just changed in the last week. So I'll talk about experiences with what you will see with those delays at the front door in the immediacy, and then I'll talk about the second part. So the first part is that Royal Berks were operating a single front door model. Now, a single front door model can be a very challenging system, and it's brought about by geography within their hospital. They don't have the space, essentially, to hold. They don't have a big enough department, so therefore they can't hold patients in the department either. So what you will see with other acute trusts, I'm thinking about the John Radcliffe Hospital, even Basingstoke, University Hospital Southampton, those sorts of hospitals. It's not the fact that they don't queue, it's the fact that they queue internally. So they're within corridors, but they're being cared for by hospital staff. The difference with the raw barks, and this is no slight, please don't take this as a slight at all, is having a single front door model will grind you to a halt really quickly. So essentially everything within the hospital, so they don't have they have a same day emergency care, but everything goes via the ED. So anything medically expected, anything like that has to go through the front door. So rather than maybe at the John Radcliffe, we would take directly to the same day emergency care or the single point of access or the medical assessment unit, which about 25% up in Oxfordshire, about 25% of those patients go to the wards directly, the departments directly, rather than going through the ED. You don't have that as an opportunity to do that at Royal Berks. That said, I've been working with them for probably the last 5 or 6 years, trying to help get an established pathway that we could go through. And I'm really pleased to say that only last Monday, we did start a trial of the single point of access. So what that now involves is that it's only for medical patients, which is the vast majority of patients that are going in for admission, we speak to a medical consultant and a triage nurse coordinator to try and get those patients directed directly to the same day emergency care rather than via the emergency department. It's new. There will be teething aspects to it, as you might imagine, but it is a big step in the right direction for us. So trying to keep some of those patients away, trying to stop those patients being held on backs of ambulances. The same applies to why there's delays in the department for being seen. Again, that's often because they're waiting for the patients to be moved through the department and into those other departments, such as the same day emergency care. So that is some of the big challenges that we experience. I hope that answers sort of the first part of your question. I think the second part is what happens going out into the community with care. I think what you're referring to is patients that are historically we would have, an old term would have been like bed blockers. So they're medically optimised, fit for discharge is what they're classified as. So patients who are, as well as they're going to be, able to be discharged home, and we have various different pathways that you can access. A pathway 0 would mean that you're like you and I walking around, you're able to go home, unsupported, you're fit to be discharged, no problems. And then at different levels you might need a carer once or twice a day, or even once or twice a week. You might need them 4 times a day, or you might need living care or a care home. So different pathways that can be accessed. Now, the community, the availability of community care is very, very challenging. Obviously, it's not my entire bag, but certainly from my experience of what goes on. Carers aren't paid particularly well, which is a challenge. We certainly see a drop in the amount of carers that are available in holidays, for example, so school holidays. A lot of carers are parents of younger children, so it's very difficult for them to maintain. So often they'll just take time off during that time because their pay is not as good, so they'll just, stop working, essentially work when they can and not work when they can't, which is a challenge. Care homes are, the spaces in care homes are very limited and come with, high costs as well. So there's a lot of negotiation that goes on to obviously place people appropriately. The other challenge that we come up against is around patient choice as well, so family choice as well. So, if there's somewhere that might not be as suitable for a family member travelling, for example. Again, these all add in to make the perfect storm, I suppose, for why we don't get people where they should be in the community. But I hope that helps. It's I'm not a subject matter expert on community, but it's certainly what our experiences are.
Thank you. I knew that actually the second part is obviously outside the scope of what we are discussing here, but nevertheless, all this is end-to-end service you talked about. This is all interlinked, and it does have a knock-on impact on what the services you provide as well. I mean, just the fact I was reading a report says, regarding the second part, discharge from the hospital, there was an assessment done that probably £500 million could be saved by the NHS Trust if there actually was somebody to look after the patients who are ready to go home, and the beds could be spared, but there is nobody actually to take care of them. So there's a huge saving could be made by the NHS, which means the new beds being available, which means that people don't have to wait in ambulance for too long. So everything is obviously linked here.
Yes, definitely.
Yeah, thank you.
Any further questions, anyone? I would like to say, reiterate Shahid's comments with regards to the quality of service your teams deliver. Personally, I was very ill last year, and the care I received from your teams was outstanding. Obviously, they had no idea who I was. I was just a Joe. So I would like you to make sure that you thank your teams for their outstanding quality of service.
Thank you. It's very much appreciated. I'm sorry to hear that yourself and your colleague was, had to use our services, but thank you.
Yeah, it's really appreciated, especially by my family. Sorry? Oh, sorry, Phil has a question. You haven't got off the hook yet.
Sorry. Hello, Kirsten.
Hello.
Interesting to hear about the developments. ED streaming, is that being serviced by SCAS, or is it by an alternative provider, another provider? And do you know if that is a trial, or is it just a certain chunk of money for a short time, or is that going to be something that's more permanent?
The single point of access?
Yes.
Yeah, so single point of access is something that we've worked on collaboratively. So it is between the acute trust, the Royal Berks, and ourselves. So we have a clinical care pathway team that works specifically on that, alongside myself as the assistant director of operations and head of operations in the local area. So we work together, and it's a collaborative essentially. So it provides education from our side to our staff to ensure that they're accessing correctly. The information goes on our directory for service, which in our case we have something called SCAS Connect, so we can identify the pathways most appropriate and the hours of operation. It's not 24/7, so I think it's 12 hours a day. I think they've just extended to 12 hours a day, 7 days a week, but it's not a full time. It'd be ideal for it to be 24/7 service, 7 days a week. I think we will get there ultimately. I think there's always concerns, isn't there, on the part of the receiving team, that we might deluge them, we might overwhelm them with information. But SCAS is a very data-rich service, and as such, we are very much able to report on that data and what we were doing. Essentially, how we view it is that actually these patients are going in to the appropriate pathway. They're going to the place where they're going to get their definitive care straight away. So in line with right care, right place, right time. But also it's allowing us to it's patients that usually we would have gone via GP triage. So we would have spoken to a GP to get those admissions. It's just cutting out the middleman essentially and allowing us to get direct clinical conversation with the right team of people.
And having mentioned that, is there a stream to urgent care GPs at that site too? Is that something that they're doing or they're considering doing?
Yeah, there has, but we've had a couple of trials with that with regards to the acute trust, and that's done via the ED. So they have had GP streaming that takes that through. It's something that gets switched on and switched off as per funding generally. But having GPs, I mean, we have GPs that work in our control rooms, which drastically help us with the reduction of the category 3 and category 4 calls being mobilised to, because they're often are able to be dealt with. So we do utilise that where we can, and they're very much embedded in our clinical support desks and the CAS with regards to 111 service in particular.
Brilliant. So I presume you're all having your say with regards to what you would like to see at Royal Berks, or what facilities you would like in a new hospital, was there one? And presumably, I know in the layout, that's one of the things that you'll be concentrating your efforts on getting your input in.
Most definitely, yeah. I'm part of that consultation process. So yeah, that's something that they formally consult with me in my role. But I live in the area as well, so I've got a vested interest for my own family as well.
Of course, that's great. Thank you very much. Thanks.
Shahid's got another question.
Sorry, it's a quick one, Kirsten. You know, the targets, maybe it's there, actually I missed it, right? Ambulance call, what's the word? Call out timings, you know, when the call is made. Can you remind us what are the targets and locally within which the ambulance has to, you know, obviously attend, and are we meeting those targets?
Okay, so that's a bit of it's an interesting challenge. It's because the government have changed things recently. I say recently, within the last 6 to 9 months, I would say it is. So essentially, under normal circumstances, Category 1 calls need to be responded to within 7 minutes. Category 2 within 18 minutes. Category 3s, we have various different parameters, so that might be a 1 hour, a 2 hour, or a 4 hour, and then it goes beyond that. The government have changed the target, so we still have Cat 1 as 7 minutes, which we are not meeting, but then I will caveat that not any English ambulance services are meeting either. We're not far off it. Off the top of my head, I can't remember if I put it into the pack or not. I would have to double check. Sorry, I'm just going to whiz through and see what I put into there. I could certainly provide it if not. I think I focused in on what I was asked to focus in on rather than additional sort of stuff. So essentially, the 18-minute response for Category 2 calls, the government have changed to a 30-minute response time. And that's for the whole country. That's not just for us. We are meeting that target. There are some times some days, individual days when we don't. And it seems very strange to talk about other areas within the SCAS profile, but specifically other trusts. But actually, what we've been able to very clearly evidence is the days that we do not hit our Category 2 performance target of 30 minutes are the days when we are impacted by ambulance handover delays, particularly at the Queen Alexandra Hospital in Portsmouth. And again, that may seem a little strange to be talking about what goes on the South Coast, but actually the draw is so great. And for example, last week we had over 200 hours lost in ambulance handovers just outside that one hospital. On one day, that is one single day. And that happened on a couple of occasions. What happens is that you might have 20 plus ambulances outside the Queen Alexandra Hospital in the southeast sector, so Portsmouth. So colleagues from North Hampshire will get pulled down, or even Southampton as well, will get drawn into the Portsmouth area because there are no ambulances to meet any response. That in turn then knocks back into the Thames Valley, and we end up in a position where we have to push our ambulances down into Hampshire to support that. So that is when we start to see our performance drop. It's very, very directly correlated against that. So essentially that's our challenge. So at the moment we are roughly around about between 24 and 27 minutes as an average for our Category 2 each day, but sometimes it tips over 30 minutes.
I think that's all the questions done. Many thanks, Kirsten. Really appreciate your report and your presentation. It's been really, really helpful. Thank you very much for your time.
You're very welcome. Thank you very much. I hope you have a good evening. Thank you. Bye-bye.
Bye-bye. I think we've got Jamie next for Health Watch.
Hello, everyone.
Hi, Jamie. It's all yours.
Right, so it would usually be Alice, who's the lead officer in the Wokingham area, who would be here, but she is on leave, so I am here in her stead. I'm the area director for Berkshire West, which includes Wokingham. I believe she shared a report with you already about what had been going on with Healthwatch, but I thought I'd just run through that briefly with you, and then if there are any questions or anybody would like to ask anything, Key areas of work across the last sort of 6 months or so, which would have been touched on in the last meeting as well, is the GP Access report, which has been done across the country. That report should be due in April. We are looking at a lot of feedback around accessibility and comprehension of information that is shared. We have an LD dentistry report, which is also due out around April time. We currently have a survey running on our work plan, which is due to finish this Saturday on the 23rd. The work plan is the various topics that we focus on each financial year. So we will be launching a new one in April, and that is for public consultation and feedback on the areas that we have focused on. So within that, we have an overall banner of accessibility, because that seems to be one of the big areas that is coming out of our contact with people across various projects. So we will be particularly looking at social care aspect for unpaid carers, and then looking at health inequalities for various communities within the Wokingham area. And we will be doing some extra work as well around Pharmacy First project that's been running recently. We have a new senior engagement officer for Berkshire West, so he will be covering 3 areas, but his specific role is about picking up and working together with PPGs, patient participation groups, to address public concerns, share experiences, and work collaboratively with the PPGs. And the 24-25 work plan will be out around April, and we'll also have an annual report out at the very end of June, the start of July. So that largely covers the points that were raised in Alice's report. If there is anything anybody would like to ask, I'm open to questions insofar as I can answer.
Beth's got a question.
It's not actually a question. I'd like to say congratulations. I'm not a frequent user of Facebook, but every time I look at Facebook these days, Healthwatch pops up. And that's something we've talked about in the past, about being around so people recognise the name and the purpose of the service. And I could say you're doing 1,000 times better because you pop up on Facebook. I don't know about other social media, and I suspect from that you're getting a lot more input from members of the public.
Yeah, thanks for that. I think it is going well. Our comms officer in Wokingham is Grenier, who works very hard on communicating messages across as many platforms as we can. We're also doing a piece of work at the minute across the Berkshire West area, but also the other health watches that are hosted by the advocacy people. And that's focusing on marketing materials and how we can innovate in the way that we communicate the message to people. So that is probably also where you're seeing some of that work coming through, because we're focusing on branding and branding recognition for people, so that we raise the awareness of Health Watch within the population of each borough that we operate in.
Any further questions? This PPG project is something I asked Alice for, and I'm glad to see it there. The reason I'm so concerned about PPGs was we had confusing messages about whether PPGs existed or not, and how toothless or toothful they are. And so I was very concerned. I mean, you know, all the people around this table are elected by residents, and we try and represent the residents. And one of the things that we all want, whatever party we're associated with, is that, particularly with regard to health matters, that even the little guy or the little old granny or whatever it is can, you know, raise an important issue. And that's why I believe that PPG is such an important thing, which is being missed by quite a number of big providers, especially. So I was present at another meeting, which is nothing to do with health. And I said to the people on that meeting, give me a call if you find your PPG at whichever surgery you're registered with. So I had a call this afternoon, just before this meeting, from one of the people on that other meeting, and he said, he went to the surgery today in Sandhurst, and the receptionist informed me that they don't have a PPG. And this really worries me. We need to be able to listen to what the people who are receiving the services say, and that is supposed to be the PPG. So we need to try and track those providers who are not delivering that contractual requirement. But I'm really pleased to see PPG is there.
Well, I can give you some extra info on that might help with that for you as well. The senior engagement officer working across Berkshire West is as a result of Bob themselves, so they've been providing that funding for it, and that's an area of concern for them. So far, Simon, who is our senior engagement officer, he started at the end of January, the very same time as I did. And he has been mapping out the various different areas across Berkshire West, across the 3 areas within that, looking at the PPGs, looking at the structure of PPGs, what PPGs should be doing. He's finding quite a varied approach to it at the moment. So some have PPGs, some don't have PPGs, some have PPGs that haven't met for quite a long time. Some have PPGs that are very focused on quite high level, almost like bureaucratic stuff with their surgeries, rather than the essential point of the PPG. And some of them are not focused on those areas at all. So there's a lot of work to do to get a kind of equitable standard of PPG awareness and involvement across the area. So Simon is going to be very busy across the next year.
I will really look forward to his report whenever that is ready. In the meantime, I think Jackie's got a question for you.
Well, I did, but we looked it up because we weren't sure what PPG was. So we managed to do it. Plus,
that's because you're an old granny.
Also, there are 2 old grannies in this room. Careful, better than me.
Sorry, I wasn't implying anything against. But no, it's really good to see that there is a focus on that. And I see that as really crucial. And when I spoke to Bob, they said, we have we have anecdotal evidence about X, Y, or Z surgery, but the only way I feel that we're going to really get a grip on those surgeries is have actually the patients of those services actually involved, and that's where PPGs come in. And that's why I'm so committed to this project. And this for me is absolutely crucial. Any further questions?
I was just going to say the concerning thing is the good practices will have the PPG. It's the ones that we want to focus on that don't have them, and it's how we, like Woking Medical Centre. Yeah. And I am concerned, from what Health Watch has. My fear is, what progress have we made with that centre over the last year? We had I'll be honest, we had that quite damning report from Alice, quite concerning, and just where have we gone with that? I don't really feel we've moved forward very far with that, and that's still a big grumbling issue that's going on in the background with Woking Medical Centre, which we're still not really addressing.
Well, I could probably give you a couple of updates on that.
Yes, that'd be helpful.
Usually with our reports, particularly as a large report like that, we'll look at 6 to 12 months going back to those providers and seeing what it is they have done with the recommendations that we made. So Alice has been pursuing that over the last month to two to try and get a proper formal update of what's been done. I can't share any of the details yet, but we have had some contact back from them recently. So there are some encouraging sheets there. And as far as the patient participation groups, because there is such a varying standard across the various areas, one of Simon's focuses is on encouraging a standard of involvement and expectation across the areas and relationship building with practices. So we don't want it to be a punitive thing. We want it to be a collaborative thing, and we want it to be something where PPGs and patients in general can feed back to their practices, and they can improve and make savings in terms of cost, time, effort, and that we can hopefully get some outcomes coming from that. So we are hopeful that working in medical practice will be part of that as well.
Jackie.
So how will the PPGs work then? I mean, do you write to the surgery or contact the surgery and say, do you want to join, or is it mandatory?
So the PPG, every surgery should have a PPG.
Right.
So it's an obligation for them to have one. Some have them. Some have inactive ones, I would say. So they have sort of cursory approaches to it. You know, it exists, but it doesn't meet. What we're looking at is in terms of effectiveness. So there are multiple reports out there and processes. There's a PPG website that outlines what a PPG should do and how it should benefit the people that are using that particular surgery. So there's lots of guidance out there for PPGs. It needs to be encouraged for people to follow that guidance. And
yeah, well, that's kind of the next thing, because it's patient participation. So do the patients know about it? Do you see what I mean? You know, the practice
yeah, well,
does,
some of them do, some of them don't. I mean, again, you know, part of the thing that we're looking at in terms of health inequality is that there are certain communities that don't have a voice within their local surgery, don't feel like they have a voice within their particular area. So they're not necessarily coming to the PPGs. So where there are PPGs, there is work to do around making them something where everybody feels like they can represent their voice there.
Yeah.
And each PPG should have one of the doctors from that surgery as a member of that PPG as well. So there's an opportunity for that feedback to be direct as well.
Yeah, good. Thank you.
Any further questions? No. Jamie, thank you very much for your time. Really appreciate it. Thank you for the report. We look forward to the ongoing activities, and we have a very keen eye on the PPG topic. Thank you very, very much for your help.
You're welcome. If anybody's got any other questions about Healthwatch stuff, please feel free to contact myself or Alice direct. And yeah, I will bid you good night now, if that's okay, and good luck with the rest of the meeting. Good night.
Thanks very much.
Thank you, everyone. Bye-bye.
Okay, ladies and gentlemen, we don't really, well, we don't have a work plan because there's a thing called elections coming up. And there could well be a different person sitting here and different ones sitting there. So who knows what's going to happen? Phil's nodding away there. So there's no point in having a work plan. Obviously, I think we've got a tracker or something. Are there any questions on the tracker, or Beth?
Page 39.
Somebody wrote to me literally yesterday about is the world or the council aware that there's a shortage of ADHD medication, which was surprising to me because one of my grandsons is ADHD and he has medication, but we've never been told there's short of it. But it's clear there are other things that other than Sam has. And I thought, oh, I'd bring that up. But of course, we may not be here next year, but it's very interesting because there is a shortage. And this gentleman was asking me and Catherine and Chris Johnson to bring the council to an awareness of this, what we've done. So, yeah, that's somewhere.
My response to that point is I'm not surprised, because we've had a lot of supply chain issues. We had a presentation from the pharmacy guy, and, you know, it's not recovered since COVID and Brexit. And, you know, his view was the supply chain problems are going to continue, whatever happens. There are some global issues, there's some local issues, there's some European issues. I think everybody's got issues. But the thing is, perhaps we need to remember, you know, the whole world is getting old quickly. And, you know, I look at the demographics of Japan and China and Korea and West Germany, and there's a massive number of oldies coming along the line, which means a lot more medication, and the supply chains are stressed. Rebecca.
Could I just add that I think as a priority, regardless of who's on this scrutiny panel next year, next municipal year as such, that we keep a track on Woking Medical Centre. Somehow it's in this agenda moving forward, that we monitor what's going on. And it's highlighted, and that we get an update from Health Watch about what's report. And also, I never feel we really got a satisfactory answer about what's going on there.
I think it's a topic that we should absolutely continue to follow. It's such a massive surgery with, you know, I think it's over 25,000 patients, that if it's one that's struggling, we really need to keep an eye on it. I don't know if one of the things that I talked to Ingrid about, perhaps Ingrid could join in this conversation, was, you know, when we used to ask the CCG and then the Bob ICB about planning for GP surgeries, and Rebecca's nodding her head about Arborfield and these kind of places, we used to really get no traction whatsoever. And one of the topics that we have not fully bottomed out is this planning topic, which I think we need to have as a non-public discussion. So that also needs to be tracked, because at the end of the day, our residents are saying to us, you know, there's too many residents and we're getting older, there's a lot more medication required, a lot more complexity. The number of GP surgeries is insufficient. Everybody says that. You know, there's nobody that disagrees with that. So the obvious thing is, what is the planning department looking at? Are they looking at somewhere for a surgery sometime soon, or in the next 5 years, 10 years, or whatever? So I think that will have to be deferred to next year when we have a different committee. But I would like Ingrid to take a note of that, if that's possible, because I think we need to have that meeting. Beth, please.
Thank you, Chairman. If I could say something as the current chair of licensing, licensing have, because I'm a boring person really and don't like drinking or smoking, I've done some work on being able to purchase not only alcohol underage, but also vapes and different sorts of gambling. And I hope that that committee next year, whether I'm on it or not, will carry on with that work, because I think that other side of the health work is very important. And as we come to the close of this meeting, I'd just like to say thank you to you, Adrian, for chairing, and thank you to all members of the committee who I have worked with great respect. I think we've done a reasonably good job, and thank you to the staff and everyone that's helped us to go through this, come along and provided reports. Some of us may or may not be here in the next couple of 3 months. But whatever, I'd like to say thank you particularly to you lot, because I think we work well together, especially the naughty old grannies over here.
Shahid. Yeah, I think echo the point which Beth has mentioned. I think there's a lot of obviously work goes behind the scenes, but I was just looking at the tracker as well. And there's a lot of things which actually are still ongoing, and there's some number of things which are actually hasn't been scheduled yet. So hopefully whoever comes along with the next committee, they will pursue that. And obviously Woking Medical Centre is being one of them, but there's a number of others I can see on the tracker as well. Just a comment, there's 2 comments basically, it's not a question as such. I did actually wanted to, say this when Kirsten was here regarding the ambulance call out charges and the targets. I think it's quite concerning that they were not actually meeting those targets and not being met. I've got actually personal experience only about 2 months ago where there was an accident on Reading Road in Woodley where I live, where I just happened to be walking towards Oakwood Centre, and right in front of me there was an accident where the motorcyclist hit the car and he was really badly injured, and later I found his 2 legs were broken, arm was broken. He survived, I don't know how, but lucky to be survived only because his helmet cracked basically and somehow not a cushion. But I was there for 1 hour and 15 minutes with them. A couple of neighbors were there. Police came very quickly, but it took 1 hour and 15 minutes before the ambulance came. Police were there very quickly. They cordoned off all the Reading Road from both sides, but they were frustrated. Police were frustrated as well. It says normally it doesn't take that long, but that's actually 1 hour and 15 minutes. This is my own personal experience. Happened, and it was -2 degrees at the time outside as well. So I think this is this experience, but I think Kirsten said herself that we are not meeting all those targets, category 1 and category 2. I wonder why actually it has been delayed to 30 minutes, because maybe we are not meeting the target. So what's the point of setting a target which is not being met? So let's actually make it bigger, 18 minutes to 30 minutes. I don't know what the rationale behind that as well. Just a comment, Adrian, regarding the adult social care. As we know, we talked about, we are living longer. The needs are complex and needs are complicated as well. But the way adult social care is being managed, I think, is really, I feel, is really in crisis. It has to be. We know that our budget, more than 50% goes towards this, and is increasing every year. Understand, more than £1 million is spent on that. So it's not partisan basis. It just generally is a huge issue, and the problem seems to be getting worse and worse and worse. And there seems to be no solution but nobody's seriously looking at this as a solution, because the current status is not sustainable. For the reason we mentioned before, because the care, if there's service providers, some of them are going out of business. Why? Because it's financially not sustainable. Care workers are paying so low pay. I mean, my hat's off to them, basically, the kind of work which they do, and inflation is, so all these things, I mean, again, it's a big issue, but nevertheless, I feel it's a serious issue, which needs to be looked at.
not locally, but also actually nationally as well. Otherwise, I think the problem is going to get worse and worse.
Firstly, I feel totally ashamed that we pay people what we pay people across the UK for delivering very important care services. Historically, it's been across the UK a very low paid job, but actually it's a really crucial job, and it's a really stressful job. And it's a job where you are working with people who are in the process of dying. You are, in some really, really challenging situations on a daily basis. And I'm really ashamed that our society does not raise this as a higher priority. I'm glad to see that you mentioned that we need to look at this, at central government level. There is only so much the council can do. I think every time I talk to Matt or his team, they're very enthusiastic and very focused on the people they're looking after, but they all admit there are significant challenges, and those don't go away because we're all getting older, as you said. So, it's really, really tough. And I can see why people in the teams, sometimes have to, consider, the situation they're in. But at the end of this year, if I can wrap up, I would like to thank everybody who's been on this committee. I think we've had some really expert people on this committee this year. I think the level of scrutiny has been better than I've ever seen it on this committee. Part of that is because we have a connection to Ingrid Slade, and Ingrid Slade has been supporting this committee. And I would like to specifically call out a big thank you to Ingrid for helping the many topics in the background, which has been really useful. And Madeline, who's been excellent, taking care of me, which is always a bit problematic. But I really wish everybody well in these coming elections. And I hope to see, hopefully, many of you back in this committee, because you guys have done a great job scrutinising things. Thank you very much. Phil.
I won't raise any more business now that you've wrapped up, Adrian. So I'll aim to be re-elected so that I can bring it to the attention in the very first after the election, should I get the chance to.
I'll tell you what, I'll move to Norwich and I'll vote for you, mate.
All right, buddy. Cheers.
Good night, everybody. Thank you very much.